now it's my pleasure to take us back to our invited speaker program, and I would like to introduce to you Dr. Jeannie Callum, although I suspect she probably really needs no introduction at all. Jeannie is currently the Director of Transfusion Medicine at Kingston Health Sciences Center. So many of you will know she spent a large part of her career at Sunnybrook, and she still is an associate scientist in the Sunnybrook Research Institute, but she's recently moved to Queens, where she's a professor of pathology and molecular medicine. Jeannie's also an affiliate scientist with Canadian Blood Services and maintains her professorship in laboratory medicine and pathobiology at the University of Toronto. So Jeannie, I think you can go ahead and take it away.
Okay, thanks very much, Dana. So I was asked to talk about our FAIRS study, which was using prothrombin complex concentrates for cardiac surgery compared to our standard of care in Canada, which is plasma. And so I'm delighted to communicate those results to you. Just my disclosures. So the hemostatic disturbance after cardiopulmonary bypass is a multifactorial problem, which makes it obviously really difficult to get people to stop bleeding after surgery. So the cardiopulmonary bypass circuit activates the platelets, so they're less functional as someone comes off bypass. You have hyperfibrinolysis. We routinely use tranexamic acid in all these patients, but despite that, we still have low fibrinogens coming off bypass. We have elevated tissue factor pathway inhibitor. They get released by heparin, and that reduces your thrombin generation. So you have coagulation, difficulty coming off bypass. We still have residual heparin there that we're trying to fight against. And we have residual anticoagulants and antiplatelets that the patient was on before surgery. And then, of course, we have what we call the factor 14, which is our code word for the surgeon causing hemostatic problems. And that's the code word that we use in the operating room so the surgeons don't know we're talking about them. So lots of problems. This is a report just looking at what happens to factor 2, your tissue factor pathway inhibitor, and your enhanced thrombin potential. And you can see there that your factor 2 and your thrombin potential goes down by about half, and your tissue factor pathway inhibitor goes up by half. So everything is deranged coming off. This is just work that's coming out of Jacina and Kavan Karkuti from UHN, just showing the pre to post bypass, your peak level and your thrombin potential are about 50%. But you can see it's highly variable. Some patients hold it together and other people are coming off basically with no thrombin potential post-op. Patients that drop below this ratio of 0.2 were almost 3 times more likely to need some sort of hemostatic therapy to get them to stop bleeding. So we believe that this actually means something. So there are 2 ways for us to basically boost the thrombin potential post-op. One is to use plasma. That's what we've done for 50 years. And the other alternative is to use a prothrombin complex concentrate that's made by a manufacturer that has a very stable amount of all of the clotting factors of 2, 7, 9, and 10. But these have never been really properly compared in prospective randomized trials. There are some attributes of the PCC that make them a little bit more palatable. One of them is just a lower volume. If you give a liter of plasma to a patient, you're going to drop their hematocrit and they're going to end up with more red cell transfusion. So we like the low volume. They're pathogen reduced, and you can keep them near patient because they don't have to be frozen. You can keep them at room temperature. So we can actually put them in the operating room. So we really like a lot of the attributes of PCC. This is people have tried to look at, well, what happens to your thrombin potential, whether you've got PCCs versus plasma. The graphs on the left are patients that got plasma, and the graphs on the right are the people that got PCC. But you can see there, look at the y-axis. They didn't, line them up. I don't know who was reviewing this article, but it makes it very difficult to interpret. So I've put a big 1,000 of where they would be equivalent. And you essentially get a much better correction, although again, highly variable with PCC compared to plasma. In addition, Laura Green's group out of Oxford just completed and published in Anesthesia earlier this year their Prophecy pilot of randomizing cardiac surgery patients to PCC versus FFP, but of wide ranges of dosage. And so you can see there on the left is your thrombin level and then your thrombin potential. And you can see there that to get into the gray bars from patients that got placebo compared to different dosages, you really actually need a pretty hefty dose of both plasma and PCCs to get up into that gray zone of a normal factor II level and a normal thrombin potential. So essentially she did almost like a dosing study to figure out, what kind of doses do we need to compare. These doses that are recommended here, the plasma dose is what's recommended as the standard of care of 15 mils per kilo, but the PCC dose recommended in guidelines is 25 IU per kilo, which is about 2,000 for the average size person. So this is a bit of a low ball on the dose for PCC compared to the plasma. So in systematic reviews in cardiac surgery, it suggests that if you get PCCs, you're 2 times more likely to avoid red cell transfusions. In trauma, the suggestion is you get 3 less red cells, so that it provides quite a hemostatic adjunct. And in case match controls, which are the best data that we have right now because we don't have large randomized control trials, in addition to helping with transfusion avoidance, there's some suggestion it might improve hard patient outcomes like mortality, but again, not randomized data. This is the estimate from the most recent systematic review that in trauma you might reduce mortality by using PCCs, but again, not proven in large studies. In terms of safety, there really is no safety flag for thrombosis. Everybody's worried that by giving PCCs will cause thrombosis, but for trauma and cardiac surgery, there's absolutely no suggestion that we see thrombotic events. In the studies in cardiac surgery, there was some suggestion that did not reach statistical significance that patients that got PCC had more acute kidney injury. That doesn't seem biologically plausible, but obviously going into studies, we were really worried about this particular problem that might arise and cause problems with our ability to do a large clinical trial. So with all that knowledge in our head, we went on to do the FAIR study to compare PCCs with frozen plasma in a pilot study in preparation to inform our large randomized control trial that we have submitted for funding. So our objectives were to determine the proportion of patients who received PCC but then had to cross over and get plasma, the hemostatic efficacy and safety, and the feasibility of our study procedures before we launched a multi-center trial. We included multiple different hemostatic outcomes because we didn't know what would be the best one, but we looked at things like after getting the hemostatic product, after 60 minutes, you give it time to get it into the patient, up to 4 hours and 24 hours. Do people need anything after that? Was the total number of products infused? Who went on to a severe or massive hemorrhage? And what was the chest tube drainage? So we looked at lots of different hemostatic outcomes, also to look and say, are they all going in the same direction? This is the standard score that's used in cardiac surgery. And so we were looking at people that go on to class 3 or 4, which are severe and massive. And the things that are really driving this are things like the amount of chest tube output. If you're over 1 liter, you get 5 or more red cells. You end up needing factor 7A. Those are some things that drive you into a higher category. So we wanted to see, does it reduce this? So this was a pragmatic design. The only thing we changed was the PCC versus the plasma. We included all adults that were ordered PCCs or frozen plasma during bleeding after cardiac surgery with minimal exclusions. They were randomized at the time of the order, and then we had a delayed consent, and all patients were managed with a standardized algorithm that had been proven in a previous study to reduce the chance of massive bleeding. So all their other bleeding management was controlled. So when we got this order for frozen plasma or PCC from the operating room, the blood bank techs went through the inclusion exclusion with the anesthesiologist or someone else in the room. We randomized people to 2 different dosages depending on their weight. So if they were small, they got 1,500 units. They were bigger, they got 2,000 units or 3 or 4 units of plasma. They could only get 2 boxes of product before they switched over to the standard of care, which was plasma. But as you can see, very few people needed a second dose of PCCs. And so most of the comparison was against plasma versus a single dose of PCCs. You can see there that we screened 169 patients and 131 were randomized. And during the time period, about 1,300 patients had undergone cardiac surgery. So people getting plasma for cardiac surgery, it's actually not that common. And so when you look at our efficacy outcomes, everything was going in the correct direction, suggesting that PCCs might be a superior hemostatic product compared to plasma. So going on to need further hemostatic therapy up to 4 hours was 20% in the PCC group compared to 32%. Going on to a severe or a massive hemorrhage was 21% versus 38%. Chest tube drainage was almost halved. And the total number of allogeneic blood product exposures was 9 versus 15. If you exclude the plasma used as part of the protocol, the difference was 8.6 versus 10.8. And there was just reaching statistical significance reduction in red cell transfusions from 2 units and 3 units. And this improved possible efficacy was not offset by increased side effects. So patients that got PCC did not have increased rates of thromboembolic complications and fortunately acute kidney injury, and at least comparable, possibly better hard outcomes like duration of mechanical ventilation, ICU stay, and length of hospitalization. So looks very, very promising for a future large randomized control trial. So in summary, for the management of bleeding during coagulation factor deficiency, during or after cardiac surgery, this pilot RCT suggests that PCCs may be more effective without compromising safety. And obviously we need definitive multi-center randomized trials, and we are in the process of submitting to funding and trying to get through both Health Canada, FDA discussions to make this happen. And the dose that we're going to be using is the dose that we used here. We had large numbers of conversations with the Laura Green's group out of Oxford that did the prophecy study, and they also will be going on to do future studies again with the same dose of 25 IU per kilo, which is aligned with the current guidelines. So with that, I'll stop, and I'm happy to take questions.
Thanks very much, Jeannie. So again, you can put your questions in the chat box or you can raise your hand. Happy to hear from you. Dr. Conway, come off mute.
Oh, here we go. Hi, Jeannie. That was great. I have just a question about, if I'm not mistaken, there's still like 20% serious bleeding. So why is that? And does that mean you've shifted it down and those are all surgical bleeds? I hope there's no surgeons on the call.
Yeah, so it's very difficult to, determine what is a surgical bleed and what is not a surgical bleed. When you take a patient back to the operating room, they say, oh, well, yes, we had to tie off that thing that was bleeding, but there's coagulopathic type bleeding everywhere. So that's pretty hard to determine. Remembering in cardiac surgery, when you bleed, the first thing we do now is we give them fibrinogen concentrate because we know what their fibrinogen is through using point of care testing in the operating room with ROTEM or TEG. And then we give platelets. We give the platelets based on a test called Platelet Works. So we give that, and then we go on to get plasma. So by the time we're getting to the plasma, some of those patients are already at the point of they've reached the next level and they've hit 5 red cells. And as soon as you hit 5 red cells, you're into a severe category. People have looked at if you were more aggressive up front with giving PCCs and fibrinogen concentrate right from the get-go, with the first sign of bleeding, could you prevent the downstream effects? We don't know that. All we're trying to answer is, could we just get rid of plasma and use PCCs and have either the same or better outcomes? And then cardiac surgery patients would get less non-pathogen and activated products. So once Dana gets us pathogen inactivated platelets. All will have are red cells that are not pathogen activated for cardiac surgery, and particularly for younger patients having cardiac surgery that might live long enough to see the next transfusion transmitted infection. Will be ahead of the game.
And can you just comment on the economics?
Yeah, so the economics obviously depend on where you are. Probably in Canada, this is looking at double the cost for the product. But that product cost doesn't include the fact that you could have used that plasma to make albumin and IVIG. Yeah. And it doesn't take into the account, well, if you can get that patient to stop bleeding faster, they get out of the cardiac operating room, so those nurses can go home, so you're not paying overtime to the nurses. The patients might get out of the ICU a half a day earlier, and that's going to save money. So I think you have to look at the global costs. We are looking at the global costs for cardiac surgery from the FIBRES trial of fibrinogen versus cryoprecipitate at the hospitals that participated in it. So I think you'll be interested to see that even though, say, fibrinogen concentrate is more expensive, maybe the overall cost of the care is actually lower. And so I think we need to look at the healthcare system instead of in these silos of, oh, well, who's paying for that and who's paying for this, and look at, well, what is the total cost of the patient? And at the end of the day, let's just go with the cheapest thing. And as a taxpayer, I'd appreciate that.
Other questions, comments? It looks like you'd also save us a unit of red cells, Jeannie.
Yeah, every red cell I think counts.
For sure.
Then you wouldn't have to send us the ones with the poor stores with their G6PD deficiency and all the other problems they might have. Yeah. Maybe you could be a little bit more selective about the red cells you send us.
That's our ultimate goal for sure.
I think Dave Farrell has a question in chat.
Oh, sorry. Yeah, Dave Farrell would like to know, has anyone compared FFP to whole blood for this use?
No, but the whole blood, obviously the whole blood story is in want of a randomized control trial of some quality. There was a trial called the Combat that just compared, your components with whole blood for trauma patients. And you wouldn't be surprised that there was no difference because, of course, you're just taking the same thing and remaking it at the bedside. I think if you're going to compare whole blood, you'd really want to look at that pre-hospital where giving whole blood is actually so simple. But if you're in a trauma room, we have 50 doctors in the trauma room, there's no problem giving component therapy in a large academic center, but maybe in a pre-hospital, a smaller hospital, in a helicopter, maybe that's might be useful, but yeah, we need studies.
And then there's one more question here wanting to know if you looked at whether there were any intergroup differences in desmopressin use.
So we don't use DDAVP at the two centers where we did this pilot study. DDAVP in clinical studies in cardiac surgery has been shown to increase your risk of MI twofold. And so efforts are underway trying not to use DDAVP for any cardiac surgery patients.
Thanks, Jeannie. Other questions? Well, it's very interesting. We'll be looking forward to the results of the next project. Yes. Thank you very much.
Thank you.
For that. Yeah, great.